All right, and last but certainly not least, we have Wendy Ho, who will be talking to us on an update of colorectal cancer screening. Dr. Ho earned her medical degree from Albert Einstein College of Medicine, and then did both her internal medicine training and gastroenterology fellowship at Massachusetts General Hospital. During her fellowship training, she also received a Master's of Public Health at Harvard School of Public Health, and then she came over to UCLA in 2008 to join our faculty and has been practicing in Westwood. Wendy.
Good afternoon, everyone. It's such a pleasure to be here, and I'm so honored to be here today to talk about colon cancer screening with you. So, let's see. The objectives of my talk today will be to go over briefly the epidemiology of colorectal cancer screening and to go over the pathophysiology, the goals for colorectal cancer screening, what the methods are for colorectal cancer screening, and some future technologies. There is a new handout as well. If you don't have it, there's some in the back, but I think that most people shouldn't have it already. So, how important is colorectal cancer? Well, it's a very common and a lethal disease. It's the second most common cancer in women and the third most common cancer in men. And in the US, it's the second most common cause of cancer death. In fact, 1 in 3 people who are diagnosed with colorectal cancer actually die of it. But it's a very preventable and treatable cancer, and screening actually prevents deaths. Earlier diagnosis saves lives, and if colorectal cancer is diagnosed while it's localized, the 5-year survival is actually really good. It's 90%. If regional disease is diagnosed, it decreases slightly to 68%. However, if distant metastases are present at diagnosis, the 5-year survival decreases dismally to 10%. So let's talk a little bit about the pathophysiology, about the colon cancer and how it forms. And that'll sort of explain how we can prevent it. So regarding the adenoma carcinoma sequence, adenomas can turn into carcinomas. Adenomas are very common polyps that are very, very common in adults over the age of 50. In fact, they make up 50 to 66% of all colon polyps. However, very few of them actually progress to cancer. In fact, fewer than 5% of these adenomas progress to cancer. And it takes about 7 to 10 years for these adenomas to actually develop into colon cancer. And so, hence, that's why we start screening people at age 50, because adenomas are very common in patients starting at age 50. And at baseline colonoscopy, if there are no adenomas present, it takes about 7 to 10 years for any small adenomas that are microscopic to actually develop into colon cancer. So that's why if at baseline colonoscopy, there are no colon polyps, or no colon adenomas, the recommended guideline is that you have a repeat colonoscopy in 10 years. So another pathway by which polyps can turn into colon cancers is through the serrated polyp pathway. So these polyps are called sessile serrated adenomas, and they're very common in the proximal colon. They're difficult to diagnose. Here is a sessile serrated adenoma that I diagnosed in a 70-year-old woman who came in for a routine colonoscopy. So the polyp is right here, and you can see here it's a little bit difficult to distinguish where the polyp starts and where it ends. When I injected it with methylene blue, the polyp becomes much more apparent, and this is the polyp site after it was removed with snare polypectomy. These sessile serrated polyps characteristically have BRAF 600E mutations that turn into sporadic microsatellite unstable colorectal cancers. And what's interesting about these sessile serrated adenomas is that they lack the classic dysplasia that's typically seen in adenomas. But if classic dysplasia is present in these sessile serrated adenomas, that's a very important step in cancer progression. So to summarize, adenomas and sessile serrated adenomas are precursors to colorectal cancer, and their removal will prevent colorectal cancer. So what are the different methods for colorectal cancer screening? So you can divide them up into 2 categories. So the first category are structural tests that examine the whole colon and that detect polyps and cancer. And these include colonoscopy, flexible sigmoidoscopy, double contrast barium enema, and CT colonography. The second category are stool tests that primarily detect cancer, and these include fecal occult blood tests, fecal immunochemical test, and the stool DNA test. The stool DNA test is actually not commercially available in the US right now, but I included it because it was mentioned in the last set of guidelines. So let's move on to flexible sigmoidoscopy. This examines the lower half of the colon, the rectum, sigmoid colon, and the descending colon. A partial bowel prep is used. Sedation is not typically used, and so patients may have discomfort during the procedure. There is a small risk of perforation of less than 1 in 20,000, and if adenomas are found, colonoscopy is recommended. So how effective is flexible sigmoidoscopy? Well, it's been shown that flexible sigmoidoscopy decreases colorectal cancer incidence and mortality. In one study that followed 170,000 patients in the UK, 1/3 of the patients were randomized to once only flexible sigmoidoscopy with follow-up colonoscopy only if there were positive findings. The other 2/3 of the patients are randomized to the control group. They were not offered colon cancer screening. And these patients are followed for a median of 11.2 years. And at the end, what they found was that the colon cancer incidence decreased by 23% in the patients who were screened with once only flexible sigmoidoscopy. And the cancer mortality decreased by 31%. So then what they calculated was that the number needed to be screened to prevent one colorectal cancer diagnosis was 191 patients. And the number needed to be screened to prevent one colorectal cancer death was 489. However, you can ask, well, we know that it decreases colorectal cancer incidence and mortality, but how good is it really at preventing colon cancer? After all, you're only looking at half the colon, and the guidelines are such that if you find an adenoma in the lower portion of the colon, then that mandates a full screening colonoscopy. So if you have an adenoma in this portion of the colon, then you're at higher risk of having an adenoma in this portion of the colon. But is the reverse true? If you don't have any polyps in this portion of the colon, does that mean that you won't have any adenomas or even neoplasms in this portion of the colon? Well, let's take a look at the data. So data actually shows that for flexible sigmoidoscopy, 50 to 60% of proximal colon lesions would be missed with flexible sigmoidoscopy. In year 2000, there were 2 big studies that were done. So in the first study, 2,000 patients in a company were offered colonoscopy. Of these, 50 of them had advanced proximal neoplasias. And of those, 62% of these patients did not have any distal lesions that would have warranted a full colonoscopy. So had these patients been offered only flexible sigmoidoscopy, these proximal lesions would have been missed. In the second group of patients, 3,000 VA patients were offered colonoscopy. Of these patients, 169 of them had advanced proximal neoplasia. And of these, 52% of these patients did not have any lesions in the distal colon that would have warranted full colonoscopy. So again, had these patients been offered flexible sigmoidoscopy as their screening option, these proximal lesions would have been missed. So Dr. Dan Podolsky, who was the chief of gastroenterology at Massachusetts General Hospital when I was a GI fellow, he summed it nicely by saying, relying on flexible sigmoidoscopy is as clinically logical as performing mammography of one breast to screen women for breast cancer. It is time to go the distance. So let's move on to colonoscopy. So we're going the distance. Not only are we looking at the distal half of the colon, we're looking at the proximal half as well. So we're looking at the whole colon. This is the most commonly used screening test. The whole colon is examined. Adenomas are removed, suspicious large lesions are biopsied. A complete bowel prep is required, and conscious sedation is offered. So patients may have to miss one day of work, and they typically require chaperone for the ride home. Here are some examples of lesions that are typically found on screening colonoscopy. So these are tubular adenomas. Here is a colorectal cancer in the ascending colon that was found in a 90-year-old woman who presented with anemia. So how effective is colonoscopy? When we went over some of the data for flexible sigmoidoscopy, but how effective is colonoscopy at preventing colon cancer? Well, the data has shown that removal of colon adenomas can reduce the incidence of colorectal cancer. But are these lesions are these the lesions that would have caused cancer death in the end? Well, the same researchers followed the same group of patients over time. And what they found was that the removal of cancer adenomas actually can prevent death from colorectal cancer. So this study was done as part of the National Polyp Study. 2,600 patients had a colonoscopy, and their colons were cleared of polyps. If they had polyps at the baseline colonoscopy, they had repeat colonoscopies every couple of years. They were followed for a total of 16 years. And what the study showed was that in these patients, there was a 53% reduction in colorectal cancer mortality as compared to the expected colorectal cancer mortality in the general population. And this is from SEER data. So this was the first study to show a colorectal cancer mortality benefit for colonoscopy. So this was really a landmark study. There are some risks to colonoscopy. The overall complication rate is about 2.8 per 1,000 screening colonoscopies. There is a risk of perforation. In screening patients overall, it's about 1 in 1,000, but this is increased with older patients and in patients with diverticulosis. So in the Medicare population, it's increased to 1 in 500. There is a risk of bleeding post-polypectomy, and that rate is 0.21%. There are complications of congestion. These are actually the most common risks of colonoscopy, and these occur in about 5.4 per 1,000 procedures. Colonoscopy is not perfect either. There is a miss rate, and so lesions can be missed. So in one study, which was a review of 6 studies involving 465 patients with tandem colonoscopies, so these are patients who had 2 colonoscopies back to back, what they found was that for large lesions above 1 centimeter, there was a 2% miss rate. And in smaller adenomas, there was as high as a 26% miss rate. So if you get a baseline colonoscopy, how often do patients need to come back for a repeat colonoscopy? So if there are no polyps or if there are small hyperplastic polyps, 10 years. If there are 1 to 2 small tubular adenomas, 5 to 10 years. 3 to 10 tubular adenomas or adenomas with any advanced features, 3 years. Similar times for the sessile serrated polyps, and if there's a serrated polyposis syndrome, every 1 year. What if the patient says, well, I think that colon cancer screening is very important. I agree with you. But I just don't want an invasive procedure. I do want, however, an exam that examines the whole colon. Then what are the options? Well, there are 2 options here. So those include double contrast barium enema and CT colonography. So let's go on and talk about those. Double contrast barium enema is a test where barium coats a colon mucosa and air distends the lumen. Multiple x-rays are taken with the patient in different positions, and patients do need a complete bowel prep. So here are some examples of barium enema images. This is a carcinoma in the cecum. Here is a pedunculated polyp that corresponds to this polyp here. And here's an apple correlation. This is a colorectal cancer that was picked up by barium enema. If there are positive findings, colonoscopy is recommended. And if same-day colonoscopy is not available, the patient may need to come back for a second bowel preparation. The sensitivity is about 80 to 90%. However, there are no randomized controlled trials to evaluate the efficacy of barium enema. There are some risks. There's radiation exposure, and there are rare cases of perforation that have been reported. CT colonography is the next study. This uses CT images to reconstruct 2D and 3D images of the colon. It has a pretty high sensitivity and specificity rate. Here are some pictures from CT colonography. So these are reconstructed images of the colon. Here is a pedunculated polyp in the cecum. You can see the appendiceal orifice right here. This is a 3D image from CT colonography. Here's a 2D image of the same polyp, again in the cecum, and here's optical colonoscopy, showing the same polyp here, and again, the appendiceal orifice. So it shows the pictures are pretty good. Patients do need a complete bowel preparation. Oftentimes, oral contrast is also used, and this is to tag the residual stool and liquid so that the radiologist can differentiate stool from polyps. Any positive findings mandates a colonoscopy. And again, if same-day colonoscopy is not available, patients may need a second bowel preparation. There are some risks to the CT colonography. There can be discomfort because rectal tube is used to insufflate air and no sedation is used, and there is a risk of radiation exposure. So what if your patient comes back and says, I really do think that colorectal cancer screening is important, but not only do I not want an invasive procedure, I don't want to undergo the bowel preparation. I've heard from my family members or friends that the bowel preparation is the worst part. of cancer screening. So then your options include stool tests that detect primarily cancer. So those include fecal occult blood test and fecal immunochemical test. So let's move on to talk about those. So fecal occult blood test detects blood in the stool through the pseudoperoxidase activity of heme or hemoglobin. You do need quite a few samples, and regarding data regarding its efficacy, 3 large prospective randomized controlled trials has shown that fecal occult blood testing detects cancers earlier than unscreened patients. Also, there is data to show that fecal occult blood testing can decrease mortality associated with colorectal cancer screening, with colorectal cancer. So fecal occult blood test, there are some dietary restrictions, though, that can be burdensome to patients. One needs to avoid aspirin, NSAIDs, need to avoid some meats, avoid some fruits and vegetables, and avoid vitamin C. The sensitivity and specificity is highly variable depending on the brand, the collection technique, the number of samples taken, and whether or not the samples are rehydrated prior to testing. And in addition, at the end, if the fecal occult blood test is positive, a colonoscopy is mandated. So let's move on to the second generation fecal stool test. It's called fecal immunochemical test. This detects only the hemoglobin, so it doesn't detect upper GI bleeding because the globin is digested in transit. It also doesn't detect foods with peroxidase activity. So it's a little bit less demanding than fecal occult blood test. It only requires 1 or 2 samples. There's no need to restrict the diet or to stop any medications. There's automated analysis, which is important for quality assurance. However, the sensitivity does decrease with delay in mailing and processing due to hemoglobin degradation. And also, it's more expensive than FOBT. Also, regarding FIT versus FOBT, there's no clear pattern of superior performance. Depending on what you're looking at, sometimes FIT is superior, sometimes FOBT is superior. However, overall, FIT is easier for patients. And in conclusion, if you have a positive FIT, that mandates a colonoscopy. The next generation of stool testing is a stool DNA test, and this identifies DNA markers in colorectal cancer cells in stool. It has a high detection rate of early stage colon cancer, and it's more sensitive than FOBT. For high-grade dysplasias, the sensitivity is 40% versus 14%. Positive stool DNA test does mandate a colonoscopy. As mentioned before, it's not currently commercially available in the US, but one company has applied for FDA review, and they're hoping that it can get done early this year. Looking into the future, there's a colon capsule endoscopy, which has just been approved by the FDA for the indication for patients who had incomplete colonoscopies. It's a capsule the size of a vitamin pill. There are 2 video cameras, 1 at each end. It takes 35 pictures per second, and once it's swallowed, it takes 10 hours of photos. The sensitivity is about 80%. It's a little bit more specific for the larger lesions, less specific for the smaller lesions. The advantages are that it's non-invasive. There's no sedation required, no insufflation of air required. The disadvantage is that it does require more bowel preparation than the colonoscopy. The capsule is very small. The cameras are not as high resolution as the pictures are taken are not as high resolution as at colonoscopy. And so one's colon does need to be cleaner in order to have high quality pictures to detect the polyps. There are some risks as well, and those include capsule retention and aspiration. So we've talked about all these tests, but what are the costs of these different tests? So at one institution, the private pay costs are as follows. This is a column, and over 10 years, this is what someone who doesn't have any polyps can expect to pay. In 10 years, over 10 years, the fecal occult blood test would be the cheapest test for one to have, and the colonoscopy and flexible sigmoidoscopy would be the most expensive tests for one to have. So how cost-effective are these colorectal cancer screening techniques? Well, there was a review of 32 unique cost-effectiveness models in 55 publications. And what they unanimously concluded is that colorectal cancer screening is cost-effective and, in fact, is cost-saving as compared to no screening. However, what they did not agree on is which test is most cost-effective. And that was due to different assumptions that each model made and input of different test sensitivities. They also did agree that the newer technologies are not yet cost effective, and those include CT colonography, stool DNA testing, and colon capsule endoscopy. So in summary, colorectal cancer is a preventable and treatable cancer. And the goal of colorectal cancer screening should be to prevent colon cancer by removing precursor lesions. Screening prevents colon cancer deaths and is cost effective. FIT as compared to FOBT is easier for patients, however, it is more expensive. Colonoscopy at this point is a preferred method of colon cancer screening because it examines a whole colon and it removes precursor lesions. There are newer technologies such as stool DNA and the colon capsule endoscopy, and perhaps we'll be using them a little bit more in the future as well. Thank you.